Hello, I'm Joel Gross, and I'm pleased to be talking to you today about renal and bladder trauma. I have no relevant disclosures. We'll start with renal trauma. The format of this portion of the talk is as follows. We'll start with a brief introduction, review some common and typical renal injuries, review injury grading, review imaging protocols, and then we'll go a little bit beyond the basics. Renal trauma occurs in about 10% of patients with abdominal injury. 90% is due to blunt trauma, and the kidney is the third most commonly injured organ in adult blunt abdominal trauma. Now, why should we image these patients? In the 1950s and 60s, renal exploration often led to nephrectomy. Yet less than 2% of patients with blunt kidney injuries require surgery, and many of the penetrating injuries can also be treated non-operatively. Thus, accurate characterization of the injury can produce improved outcomes with appropriate management, whether it's conservative or surgical. Why bother grading? It's a research tool that allows comparison of data between institutions. The OIS grade is used to calculate the Injury Severity Score, or ISS, and the ISS correlates with patient outcome and likelihood of death. Our surgeons often want an assigned grade. Now, what's different about the kidney versus other organs, such as the liver and the spleen? It produces urine, and this affects imaging protocols. It's retroperitoneal, and so we can miss injuries on a fast scan, a diagnostic peritoneal lavage, or with peritoneal exploration. Let's turn now to injury types and grades. The American Association for the Surgery of Trauma, or AAST, Organ Injury Scale was published in 1989 and is the most commonly used grading system over the past decades. This will be the focus of our talk. We will discuss the newer grading systems as well. Here we see a simplified description of the organ injury scale. And this diagram nicely shows us the types of injuries it covers. Grade 1 injuries are contusions and subcapsular hematomas. Grade 2 injuries are superficial lacerations and perinephric hematomas. Grade 3 injuries are deeper lacerations but without collecting system involvement. Grade 4 injuries extend into the collecting system or are contained main renal artery and vein injuries. And grade 5 injuries are shattered kidneys or renal hilum avulsions. Here we have an example of a grade 1 injury with a contusion, which demonstrates persistent contrast material staining on the delayed images. Here's another grade 1 injury, a subcapsular hematoma, which present as a round or elliptic hyperattenuating fluid collection, which indents or flattens the renal margin, as seen here. A grade 2 injury is a superficial laceration defined as less than 1 centimeter, while a grade 3 injury consists of a deeper laceration greater than 1 centimeter. Notice that I'm showing you the delayed images here to show you that it's a deeper laceration but without urinary extravasation. Grade 4 injuries have urinary extravasation due to a laceration extending to the collecting system. Another grade 4 injury is a main renal artery or vein injury with a contained hemorrhage. These are rarely seen. Grade 5 injuries are shattered kidneys or renal hilum avulsions, again, rarely seen. Now, there are other important injuries that are not explicitly specified in the AAST system. These include main renal artery traumatic thrombosis, which can lead to renal infarction, segmental renal artery injury leading to segmental infarctions, pseudoaneurysms as shown here or arteriovenous fistulas, and collecting system injuries without a renal lac. Newer grading systems have been developed. A 2011 proposed update included some of these previously excluded injuries, but the revision was not clearly incorporated into the official AAST system and was not listed on the AAST website, leading to variable adoption. There was no significant change in grade 1 through 3 injuries. They included the following injuries in grade 4: segmental renal artery and renal vein injuries, and all renal collecting system lacerations. And they included all main renal artery and renal vein injuries in grade 5. An updated grading system was published in 2018. The 2018 update clarified a number of injuries and added or updated injuries, such as grade 3 injuries to include pseudoaneurysms or arteriovenous fistulas, or active bleeding within Gerota's fascia. Grade 4 injuries to include segmental or complete renal infarction due to thrombosis without active bleeding, or segmental renal artery or renal vein injury, or active bleeding beyond Gerota's fascia, or all collecting system injuries. Grade 5 injuries included devascularized kidney with active bleeding. Now, is this 2018 update what everyone is using? And the answer is not yet. While the paper states that the OIS has been reviewed and approved by the board of the managers of the AAST, it's not on the AAST website as of May 2019, and it's not been widely and consistently adopted. So we'll continue to use the original 1989 system for this lecture. Now, this might all seem complicated and scary, especially if you don't do much trauma or if you're unsure what classification system to use locally. But the most important thing is simply to describe the findings which allow the injury to be graded. And most of these are findings that you would normally report regardless of the grading system in use. So what should you report to cover all or most needs? A contusion, subcapsular hematoma, laceration, and specify its depth so they can tell if it's less than or greater than a centimeter, shattered kidney, urinary extravasation, UPJ disruption, a hematoma or active bleeding, and specify whether it's within or beyond Gerota's fascia, pseudoaneurysm or arteriovenous fistula, segmental renal artery or renal vein injury, segmental or complete renal infarction, main renal artery or renal vein laceration or hilar avulsion. So let's start now with an illustrative case. And here we see a patient who's undergone some trauma. There are some deep lacerations in the kidney. And this is a grade 3 injury. Are we done with our imaging? The answer is no. Delayed images are required because there's a laceration and perinephric fluid. Delayed images were obtained, and here we see there's urinary extravasation, and this upgrades the injury to a grade 4. Now, this example helps us understand our renal imaging protocols. While indications exist for when to image renal trauma, we rarely image a patient just for renal trauma, and we essentially always do this as part of an evaluation of their abdomen and pelvis. So we won't spend time on the indications, although there are some references below. The kidney differs from other organs due to production of urine. And so while fluid adjacent to other solid organs following trauma could be, and is usually, hemorrhage, fluid adjacent to the kidneys or ureters is hemorrhage, urine, or both. Here I show our current protocol at Harborview Medical Center, where we inject 125 cc's of contrast. We scan the patient during the venous phase to evaluate the parenchyma and vessels using a fixed 70-second delay. We scan from the dome of the diaphragm to the ischial tuberosities. And if there's a renal injury or fluid around the kidney or ureter, we get 10-minute low-dose delayed phase images through that region to evaluate for urinary extravasation. We limit the scan to the region of interest and don't scan the entire abdomen and pelvis. Arterial phase imaging is occasionally helpful, but it increases radiation. The 2018 OIS updates recommend both arterial and portovenous phase imaging, but this may not be performed at all facilities. Arterial phase imaging is not obtained in our trauma CT abdomen and pelvis protocol to minimize radiation. However, when we do a pan-scan protocol, we do arterial phase imaging through the chest, which extends through the upper abdomen and does include the kidneys. Delayed images are important. This may seem obvious, and they're recommended when a renal injury is known or suspected. But we still receive many transfer patients without the necessary delayed images. Here's an example of a report where they very nicely identified a prominent laceration in the lower pole of the left kidney with a large perinephric hematoma, but there was no comment that delayed images were not obtained and that we can't exclude urinary extravasation. If you're unable to check if delays are needed in real time while the patient is in CT, and if you see a renal injury or adjacent fluid, you can either bring the patient back for delayed images, or you can simply state that you cannot exclude urine extravasation without delayed images. Now, when should we perform delayed images? Many or most institutions do this at about 5 minutes. But some of these institutions detect only 50% of urinary extravasation on initial imaging. A 2019 study demonstrated that increasing the time to the excretory phase is positively associated with finding urinary extravasation at the initial CT scan. And they state that a 9-minute delay between the early and excretory phases optimized detection of urinary extravasation. This corresponds to approximately a 10-minute delay from the start of contrast injection, which is what we do and recommend. Let's now go beyond the basics. Our next case has 3 images showing damage to the kidney. 10-minute delayed images are also available. So how would you grade this injury? Our findings are multiple deep lacerations through the mid-portion of the kidney, a large amount of perinephric fluid, but no urinary extravasation on delayed images. So this would be diagnosed as a grade 3 injury. Follow-up imaging was obtained, and when we compare it to the initial images on the left, we see that in the follow-up images, we do see urinary extravasation. This is an example of the progression of severe grade 3 injuries. On initial imaging, a clot may occlude a laceration extending into the collecting system. Urokinase can lyse this clot over time, allowing the collecting system to communicate externally, and urinary extravasation to occur, thus upgrading an injury from a grade 3 to a grade 4. Our lesson is that we may need to follow up severe grade 3 injuries. Unfortunately, there are no clear criteria as to which injuries require follow-up imaging and when to obtain follow-up imaging. At our institution, severe grade 3 injuries undergo a urinoma protocol 2 to 3 days following injury or prior to discharge if that is earlier. A urinoma protocol is not a trauma abdomen pelvis CT, and it's not a CT IVP. It's a low-dose CT specifically designed to evaluate for urinary extravasation. It's a low-dose, non-enhanced CT as a first phase to evaluate for residual contrast from a prior CT. We then inject IV contrast and wait 10 minutes and obtain 10-minute low-dose images through the region of interest only. Note that there are no parenchymal phase images unless they're specifically indicated at this time. Here's an example. On the initial study, delayed images, we see that there's urinary extravasation from this kidney, which happens to be a horseshoe kidney. For our urinoma protocol, we start with a low-dose non-contrast image to see if there's any residual contrast from the prior study, and here we see there's none. And then we inject our contrast, wait 10 minutes, and scan the patient, and we see that there is persistent urinary contrast extravasation on the right. Our next case, we see images from a portal venous phase and delayed phase. Notice that there's no parenchymal laceration, but we see contrast in the renal sinus and around the ureter. The diagnosis here is a fornical disruption. Let's review the fornix. These are the corners of the calyces as seen on these coronal and axial images. Blunt trauma can increase intra-abdominal pressure, leading to increased pressure in the collecting system and a tear in the calyceal fornix. This can lead to urine and contrast extravasation. Contrast can pass from the fornix, down the minor calyx, along the infundibulum, along the pelvis, and finally out into the periureteral space. The diagnosis is made if there's no parenchymal or collecting system laceration and there's contrast within the renal sinus. In contrast with ureteral lacerations, we'll see periureteral contrast, but it rarely dissects retrograde back into the renal sinus. Traumatic forniceal disruptions usually resolve quickly without intervention. Short-term follow-up imaging can be obtained to confirm resolution. At this point, we're pretty good at evaluating for urinary extravasation from a variety of causes. But let's look at one more case. Here are the portal venous phase images, and we notice that there's a dilated collecting system, fluid around the kidney, and some hyperdense material within the collecting system. Are we done? No, delayed images are required because of the fluid around the kidney. Here are the 10-minute delayed images. Are we done at this point? No. We have a dilated collecting system and it's not distended with contrast, and so it hasn't adequately been challenged to look for a leak. The patient was brought back for 3-hour delayed images, and now we see contrast distending the collecting system, and we're able to diagnose urinary extravasation. This is nicely demonstrated in these coronal images on the left in the parenchymal phase, in the middle with 10-minute delayed images, and some contrast in the collecting system, and finally at 3 hours with contrast, nicely filling the entire collecting system, we're able to see the urinary extravasation. So our teaching point here is that urinary extravasation has not been adequately evaluated for until the collecting system is distended with contrast. A dilated collecting system may require longer delayed images to fill and distend the collecting system. Other options are to move or roll the patient around to distribute contrast, but this can only be done once the spines are cleared. Let's briefly talk about at-risk kidneys. At-risk kidneys are abnormal kidneys, as the amount of trauma needed to damage an abnormal kidney is often minimal. The evidence for this is that injured abnormal kidneys are uncommonly associated with other abdominal injuries and have significantly lower ISS scores. Injuries caused mainly by low impact velocities. Kidneys predisposed to injury include those with tumors, those with cysts, kidneys with hydronephrosis, and here we see a tear through the thinned parenchyma, and ectopic kidneys, such as those in the pelvis, and horseshoe kidneys. Let's briefly talk about some new developments. A nomogram was recently published to predict the need for bleeding interventions. There are multiple factors that the clinician looks at. They'll look at trauma mechanism and hypotension, but the radiologists can help them with the concomitant injuries, vascular contrast extravasation, pararenal hematoma, and hematoma rim distance. Pararenal hematoma is defined in this paper as a hematoma that extends beyond the aorta on the left, or beyond the inferior vena cava on the right, or that extends inferior to the aortic bifurcation into the pelvis. The hematoma rim distance is the longest perpendicular distance from the renal parenchymal border to the hematoma border on axial images. In other words, the thickness of the hematoma on axial images. If this nomogram is adopted by surgeons, we will need to report the presence of a pararenal hematoma using the definition provided in the paper and the hematoma rim distance. So in summary, we've reviewed the common and typical renal injuries. We've reviewed injury grading. We've reviewed imaging protocols and the selective need for delayed images and when and how to perform a CT urinoma study. And we've spent some time going beyond the basics. Let's move now to bladder trauma. The format of this portion of the talk is we'll start with a brief introduction, review the classification and appearance of bladder injuries, review imaging protocols and indications, and review some cases and challenges. Bladder injuries due to blunt abdominal trauma are rare, occurring in 1.6% of blunt abdominal trauma cases. 90% are due to motor vehicle crash, motorcycle crash, or car versus pedestrian. Contusions are by far the most common injury, followed by extraperitoneal bladder rupture, intraperitoneal bladder rupture, and combined bladder rupture. A blunt blow to the abdomen in a patient with a distended bladder can lead to a large tear at the dome of the bladder. This can produce gross hematuria and an intraperitoneal bladder rupture. A pelvic ring fracture or disruption can cause an extraperitoneal bladder rupture, which is more common than an intraperitoneal bladder rupture. The majority of patients with bladder ruptures also have pelvic fractures. Only a minority of patients with pelvic fractures have a bladder rupture. And we don't want to image all these patients with pelvic fractures, so we'll discuss some guidelines to select the appropriate patients. Let's look now at the management of bladder trauma. Intraperitoneal bladder ruptures require urgent surgical repair to avoid a chemical or infectious peritonitis or electrolyte disturbances and other problems. An extraperitoneal bladder rupture can be treated conservatively with catheter drainage unless there are complicating factors, such as a penetrating injury, anterior pelvic surgery required, inadequate drainage, rectal or vaginal injuries, a low injury near the bladder neck, foreign body or bone fragments in the bladder. 85% of these extraperitoneal bladder ruptures treated with catheter drainage heal by the 10th day, and almost all of them heal within 3 weeks. Let's look now at the classification and types of bladder injury. The AAST surgical classification system is based on size and location. We can evaluate this at surgery, but cystography is not reliable in evaluating the size and also has some trouble with the location. So it's impractical for us to use this system. So what do we report? We describe full thickness ruptures, which include intraperitoneal bladder ruptures, extraperitoneal bladder ruptures, and combined bladder ruptures. There are lesser injuries that are rarely seen, such as a contusion, which is not well visualized, and an interstitial rupture, which is a tear or dissection between the layers of the wall of the bladder, which is extremely rare. Let's look now at the CT cystography appearance of a bladder rupture. A bladder rupture is diagnosed if there's extravasated bladder contrast in the intraperitoneal, extraperitoneal, or both spaces. The bladder laceration itself is not always visualized, but we report its location when it's identified. Intraperitoneal contrast accumulates in the typical intraperitoneal spaces, much like ascites. And extraperitoneal contrast is typically streaky as it insinuates between fat and fascia. Here we have an example of an intraperitoneal bladder rupture with contrast around the bowel loops and between the mesentery. More contrast is seen here in the rectovesical recess and supravesical spaces. With an extraperitoneal bladder rupture, contrast fills the extraperitoneal spaces around the bladder. This is typically streaky and irregular, and it may also form a molar tooth appearance, as shown in this example and in green on the right. From there, it can extend into the anterior abdominal wall and beyond the pelvis. A combined bladder rupture is simply an extraperitoneal bladder rupture combined with an intraperitoneal bladder rupture. Now at this point, we know what a bladder injury is. Next, we'll talk about who to image, and then we'll talk about how to image. So who should we image with CT cystography? Patients who present with one of the following: gross hematuria and intraperitoneal fluid to rule out an intraperitoneal bladder rupture, or patients with 3+ or greater microhematuria and a pelvic ring injury to rule out an extraperitoneal bladder rupture. So we do not need to image most patients, including those with gross hematuria but without free fluid, less than 3+ microhematuria, more than 3+ microhematuria if there's no pelvic ring injury, or isolated acetabular wall or iliac crest fractures. Let's move on now to CT cystography technique. CT cystogram is performed after the CT of the abdomen and pelvis to avoid any extravasated bladder contrast obscuring vascular extravasation. The technique is as follows. We drain the bladder via the catheter to eliminate dense excreted contrast and unopacified urine. We hang a bag of dilute contrast 40 centimeters above the bladder, and we instill the contrast until flow stops or it becomes uncomfortable for the patient or the contrast runs out. The catheter is clamped, and we scan once and only once through the bladder and pelvis. Now we're emphasizing this because occasionally we get outside studies in which the patient was scanned multiple times, much like they would have done in the past with a fluoroscopic cystogram. And here's an example of a patient who they scanned 4 times. Now adequate distension is critical. We need to generate a pressure of 40 centimeters of water, and we can do this by hanging the bag of contrast 40 centimeters above the bladder and letting it run in until it stops flowing. We may have to stop earlier if the patient becomes uncomfortable due to distension of the bladder. And in the literature, they say that a volume of 300 to 350 cc's is enough, but we believe that more is better unless it's limited by the other 2 criteria, and we just let the bag keep running. Here's an example of why it's important. With 100 cc's of contrast in the bladder, it looks just fine. But when more was instilled, a large extraperitoneal bladder rupture is clearly identified. At this point, you might ask, can bladder filling on delayed CT images replace a CT cystogram? Let's take a look at a few cases, and here we see on the portovenous phase and 10-minute delayed phase images, there's no evidence of bladder extravasation. But when we do a CT cystogram, we clearly see an extraperitoneal bladder rupture. You might argue, well, there wasn't much contrast in the bladder, so let's look at another case. Here in the delayed CT images, we see a large amount of contrast in the bladder and a well-distended bladder. It looks a lot like a CT cystogram. Yet when we actually perform a CT cystogram, we do find that there is, in fact, a bladder rupture. So the answer is no. Delayed CT images cannot replace a CT cystogram, as inadequate distension limits sensitivity. Let's move now to cases and challenges. Here we see some contrast beyond the normal bladder contour. Is this an extraperitoneal bladder rupture? No, this is in fact just a bladder diverticulum. It looks like one. It has smooth borders rather than the streaky contrast in the extraperitoneal spaces. Here's another example. Here we see a patient who has a bladder injury, the extraperitoneal contrast, and very nicely we can see the difference between the right-sided bladder diverticulum with the smooth walls, smooth contour, compared with the streaky contrast in the extraperitoneal spaces. Next case, we see contrast in the bladder and in the ureters, and there's a smooth collection of contrast behind the bladder. This was initially read as an intraperitoneal bladder rupture. But when you review the lower images, you'll see that there's contrast in the vagina, and the correct diagnosis here is vaginal reflux of contrast without a bladder injury. So how does vaginal reflexive contrast occur? If we look at this distended bladder, and we see this contrast in the vagina on the right image, and now we'll focus in on the urethra and blow that image up. The black ring is the Foley catheter, and there's contrast in the lumen of it. But notice that there's also contrast that's refluxing around the Foley catheter down the urethra, and that can drop back and reflux into the vagina. Next case, we see contrast external to the bladder. It looks like an extraperitoneal bladder rupture, but when we carefully window the images, we notice that the contrast is actually brighter than the contrast in the bladder, and so we need to start thinking about other possibilities. And when we looked further, we found that this was indeed due to arterial extravasation in the pelvis. This brings us to the end of our talk. So in summary, we've reviewed the types of bladder rupture and typical appearances. We've reviewed the technique and indications for CT cystograms. We've learned that adequate retrograde bladder distension is essential. And we've demonstrated that not all perivesical contrast is due to bladder rupture. Thank you for your attention.